I'm Maureen Rischmueller from the Queen Elizabeth Hospital, and I'd like to acknowledge the traditional custodians of the land and pay respect to the Kaurna elders past, present and emerging. So the theme of today's meeting is arthritis by two Australian leaders in rheumatology who are both recognised internationally for their research. The first presenter is Professor Susanna Proudman. Susanna's the Director of Rheumatology Unit at the Royal Adelaide Hospital and is the immediate past chair of the Australia Scleroderma Interest Group. She's established an Australian scleroderma cohort study with collaborations nationally and internationally. I'll cut things short because she's done so many things, but her research interests include scleroderma, including pulmonary hypertension. She's done a lot of work in that area, but also a big interest in best practice management of rheumatoid arthritis. And that will be the focus of her talk today, which is improving outcomes in rheumatoid arthritis. So thank you, Susanna. If you'd like to share your screen, we can get started.
Thank you very much for the introduction, Maureen, and for the opportunity to present some of the work by the Royal Adelaide Hospital rheumatology team in the field of rheumatoid arthritis. Rheumatoid arthritis is a chronic autoimmune disease characterised by inflammation in the joints and on occasion in other organs in the body. Untreated, it leads to irreversible joint damage, joint deformity and disability, and it is associated with the hallmark lesion of the disease, the erosion. So here we have some deformity, and this is the sort of destructive lesion you see in the joints. These erosions are essentially holes in the bone caused by the inflammation. Rheumatoid arthritis affects approximately 1% of the population worldwide and targets women 3 times more commonly than men. It affects almost all the joints of the body, although the hands, wrists and feet are typically involved in most patients. The risk factors for developing the disease include genetic factors, middle age, although any age can be affected, and lifestyle factors such as smoking, soft drinks, obesity, and serious gum disease. There have been significant advances in treatment, including improvements in the way disease-modifying anti-rheumatic drugs, or DMARDs, a term I'll be using frequently through the talk, are used, as well as new DMARDs, the biologic DMARDs being one of them. And as a result, surgery, such as joint replacements, which used to be common in the early days, are rarely required these days. Nonetheless, the life expectancy of these patients is still somewhat reduced, mostly due to accelerated cardiovascular disease, such as heart attacks and strokes. The goal of contemporary DMARD therapy is remission, and this is achieved by gaining rapid disease control in a so-called window of opportunity before there is significant joint damage. Advances in the therapeutic strategies to achieve this include the early use of disease-modifying anti-rheumatic drugs, the upfront use of methotrexate, which is one of the most commonly used drugs in this disease, and it's often used in combination with other DMARDs, and the newer biologic DMARDs that I referred to earlier. These are specially developed drugs that are targeted to specific components of the rheumatoid inflammatory joint lesion, but they do come at a significant cost to the pharmaceutical benefit scheme. In practice, these strategies have led to a highly structured approach to DMARD use, with drugs adjusted and added according to disease activity, a strategy referred to as the treat-to-target strategy. An example of such a treat-to-target protocol is used in the Royal Adelaide Hospital Early Arthritis Clinic. Patients are prescribed triple therapy with methotrexate, as well as sulfasalazine and hydroxychloroquine, which is in the first box at the top. Disease activity is assessed every 3 to 6 weeks, and the doses of these drugs are increased until the target low disease activity level is achieved, and we use a thing called the DAS28. Non-steroidal anti-inflammatory drugs, for example, Brufen that you can buy over the counter and so on, also known as NSAIDs or non-steroidal anti-inflammatory drugs, help reduce inflammation but don't prevent it occurring in the first place. And oral glucocorticoids or steroids are also actively discouraged due to their side effects. Once the maximal tolerated doses of triple therapy are reached, leflunomide, as another DMARD, is added, which in essence can be regarded as a surrogate for the failure of this triple therapy approach. Biologics can be prescribed after 6 months if the patient is eligible according to the Australian PBS prescribing criteria. All DMARDs, including the newer DMARDs, which are effective in many patients, carry a risk of intolerance and even serious toxicity, such as infection. And in addition, not all patients even now achieve remission. And in some patients, we still see significant damage and deformity. So we've been interested for many years in looking at other non-drug options that can enhance the efficacy of DMARDs without increasing toxicity. Now, I talked about risk factors before, and some, of course, are not modifiable. We can't adjust for age or gender or our genetic risk for developing rheumatoid arthritis, although some lifestyle factors that are associated with RA may be modifiable, such as smoking, obesity, and diet. In particular, we've been interested in diets rich in omega-3 fatty acids, most commonly found in fish, as these have been associated with a reduced risk of rheumatoid arthritis, even in those with other risk factors for RA, and have been shown to reduce the symptoms of joint inflammation, such as joint pain and swelling, and the need for NSAIDs. So all the patients at the RAH Early Arthritis Clinic receive a recommendation to take an anti-inflammatory dose of fish oil. And we wanted to know whether these potentially modifiable risk factors are associated with a response to therapy in early rheumatoid arthritis, as well as a risk of disease, because they may therefore be strategies for modifying these in the future to help improve outcomes in rheumatoid arthritis. So in a group of 311 patients attending our clinic with rheumatoid arthritis of less than 12 months duration, we've looked at whether any modifiable risk factors were associated with their response to DMARD therapy. Many of these patients already had recognised risk factors for RAs demonstrated in this table and also recognised as associated with worse outcomes. And these include things like certain antibodies like the rheumatoid factor and the anti-citrullonated peptide antibody, genetic risk, which we can measure using a marker called the shared epitope. A number of them have obesity, and 50% of our patients also have a history of ever smoking. As I mentioned, we also recommend that everyone in the clinic take a fish oil supplement, and we can actually measure how much they're taking, or at least provide an indication of how much they're taking by measuring the levels of one of the omega-3 fats found in fish oil called EPA in the blood using a plasma phospholipid assay. Not everyone takes fish oil in the clinic consistently, despite our best efforts, and this results in a spread of blood levels of EPA, as you can see in this graph on the right-hand side. In fact, we found that the strongest predictor of RA remission at 1 year was the blood level of EPA. That is, the higher the fish oil intake, the higher the chance of being in remission. On the other hand, smoking in people who were also obese was associated with reduced likelihood of remission, especially if they were still smoking. And this is shown in this graph here. So being obese alone, or even just being a smoker on the they didn't have much of a difference with smoking in terms of response to therapy. But when together, there was a very interesting relationship that did influence response to therapy, whereby the risk of both was greater than the risk of a poor response of each added together. So if you didn't ever smoke, just as your body mass index increased with the blue line, you were no more or less likely to go into remission. But if you'd been a smoker in the past, as your weight increased, you were less likely to, especially if you were still a smoker. It's difficult to explain this interaction. Excess fat can produce inflammatory molecules called adipokines, as well as the inflammatory molecules known to be shown to be strong drivers of rheumatoid inflammation, TNF-alpha and IL-6, for which we actually have biological DMARDs to target, and circulating levels of these cytokines are elevated in obesity. And in support of excess fat being causal, weight loss, especially after bariatric surgery, has been shown to reduce the plasma inflammatory markers and improved rheumatoid arthritis disease activity. Maybe one of the other explanations is that smoking and body mass index are actually proxies for another factor, other risk factors such as socioeconomic status, but we haven't examined this in detail yet. To confirm that enriching the diet with omega-3 fatty acids by using fish oil increases the chances of a good response to therapy, we undertook a randomized controlled trial of an anti-inflammatory dose of fish oil against the background of our usual treatment algorithm, shown again on the left. The patients in the control group, in the blue box on the right, took a monounsaturated oil containing a small dose of EPA and DHA, which come from fish oil. So it smelt and tasted a little bit like fish oil, meaning that both the patients and the trial researchers were blinded to the treatments. The primary outcomes of the trial after 1 year were failure of initial triple therapy and achieving remission of disease. You can see in the slide on the left, the rate of progression to leflunomide, that is the failure of the triple therapy regimen commenced initially, was significantly greater in each group, was significantly different in each group, with patients in the control group in red being 3 times more likely to need the addition of leflunomide. So as time goes on, more and more of them were getting leflunomide. Whereas the rate of remission in the fish oil group was double that of the control group, shown in green, even though they took fewer DMARDs. So in summary, diet, body mass index or obesity and smoking are potentially modifiable factors that have been shown to be associated with responses to drug treatment in early rheumatoid arthritis in these studies. Increasing omega-3 levels with fish oil reduces the number of DMARDs needed while increasing the chance of disease remission. And we now continue to recommend fish oil in all our patients. The results strongly support counselling for lifestyle changes such as weight loss and smoking cessation, particularly if patients have both risk factors, and for patients to take an anti-inflammatory dose of fish oil when they start treatment for their rheumatoid arthritis. We will need a randomised controlled trial, however, to determine whether weight loss in smokers would ultimately improve clinical outcomes. And I'd just like to list some of the people in our team, by no means comprehensive, and some of our funding sources for the work. Thank you.
Thank you very much, Susanna. Just with the focus on this Minireview audience, you've got such a beautifully characterised cohort of patients and so much demographic, laboratory and clinical information. Is there scope? And I know you have a number of collaborations. Perhaps you could just tell us a little bit about your collaborations within South Australia, and is there scope for other groups to get on board and with different questions?
Yes, so we've been lucky to develop collaborative relationships with people with different skills across the nation, really. So here in South Australia, we've certainly collaborated with other rheumatologists around Adelaide, including the Queen Elizabeth and outside of CALHN, looking at other genetic factors and looking at other outcomes, measuring disease activity, trying to understand some of the other factors which influence outcomes. We can certainly easily measure things, objective measures like blood tests that indicate inflammation, ESR, CRP and so on. We can measure swollen joints, tender joints, but there are other factors which influence people's response to having a chronic disease, and a particularly painful one at that from time to time, and having to take medications routinely. And recently, one of the PhD students at the Queen Elizabeth has put together some data looking at that, which has been very, very intriguing. We also have collaborated with pharmacists, an academic pharmacist at the Uni of South Australia, who has done quite a large body of work looking at our data. They've been able to look at pharmacogenomics of response to these drugs. They have a number of assays for measuring leflunomide, or at least the active metabolite of leflunomide, genetic markers for response to leflunomide, methotrexate, sulfasalazine, and other factors which influence responses. And we've also had PhD students looking at adherence to medications, so which is also a very interesting phenomenon, and to our protocol. You know, do we do what we say we're going to do? It's sort of somewhat gratifying to understand that there's usually a good reason when we don't do something, and that most of the time we do. And I think that's been borne out in our results in terms of patient outcomes. And then elsewhere in Australia, we've had collaborations with other rheumatologists who've looked at other factors like microRNA in serum, and which can be a reflection of inflammation and other processes involved in rheumatoid arthritis, and again looking at what factors influence outcomes.
Thank you. We have another question from Hamish Scott. Are there better serum markers such as cytokines that could be put into standard practice in pathology? Oh, hang on. Cytokine assays that should be put into standard practice, I guess at the pathology level, at the laboratory level?
Well, certainly many of the new biological DMARDs target individual cytokines. We also have another class of so-called targeted synthetic DMARDs, which are small oral molecules which tend to target signalling molecules, but the original biologics were targeted molecules that were predominantly large monoclonal antibodies targeting TNF alpha, IL-6, even IL-1 at one stage, and other B cell and T cell markers. And there's certainly continuing interest in identifying which cytokines or cell types are predominant in an individual's disease, because rheumatoid arthritis has traditionally been considered a very heterogeneous disease. No one person's disease is the same as another. The synovial lesion, if you biopsy it, it has no pathognomonic features which absolutely confirm that this is rheumatoid arthritis. It's a fairly a generic type of inflammatory process, but within that there are different molecules that predominate. So another collaborator who actually still comes down or up to us from Flinders, Mihir Weschelecker, who has been a stalwart of the intra-articular arthroscopy done by rheumatologists, has collected a huge bank of synovial samples and has in fact enrolled a number of our patients in a randomized control of therapies targeted to the predominant cytokine or the predominant cell type, which he hasn't fully completed yet, but he's demonstrated beautiful slides of some synovial lesions, and some patients are full of IL-6 or others are full of B cells and so on. So yes, it would be lovely to know exactly which ones to measure. The jury's still out as to whether by targeting the predominant cell types or cytokines, we can fundamentally influence responses. There's still time will tell.
Thank you. Well, if there are any further questions, please contact Susanna directly, because we're out of time, but there's, you know, huge wealth of resource for further studies. And I forgot to mention that Susanna's the Medical Director of Arthritis Australia. So thank you, Susanna. And I'll introduce Catherine. Catherine Hill is the head of the QEH Rheumatology Unit and the head of the Rheumatology Research Group at the Basil Hetzel Institute. She's current president of Australian Rheumatology Association. So we've got the two national leaders of the rheumatology groups here at our arthritis session and within CALHN. Catherine's a member of the PBAC committee. She's principal investigator of the Northwest Adelaide Health Study and previous chair of the steering committee of the ARA, that's Australian Rheumatology Database, established the South Australian Giant Cell Arteritis Registry in 2009 and has a number of research interests. And she's going to speak about the giant cell arteritis today. Thanks very much, Catherine.
Thank you, Maureen. So I'm going to talk about giant cell arteritis today. And I'm coming from the Rheumatology Research Group at the Basil Hetzel Institute. We have a number of programs of research, but I'm going to be talking about GCA today. So giant cell arteritis is also known as temporal arteritis, and it's the most common vasculitis in people over 50 years. And it's an interesting disease because it preferentially affects large and medium-sized arteries, particularly of the thoracic and aortic branches. Untreated, it has catastrophic complications, including blindness and stroke. There is some difficulty with diagnosis. It is partially a clinical diagnosis based on presence of headache, jaw claudication, but maybe as something like a fever of unknown origin, but it's diagnosed by a biopsy of the temporal artery. Unfortunately, because there are skip lesions, although this is the gold standard, it's not always diagnostic. Initial treatment is with high-dose glucocorticoids until about 18 months ago. We had no other well-proven additional treatment besides high-dose steroids. And obviously, high-dose glucocorticoids in elderly patients is quite difficult. So there is some conundrums to do with this disease. It's the commonest vasculitis of the elderly, but it's still quite rare, although it doesn't feel very rare in our rheumatology clinics. It can cause irreversible blindness and stroke. There is frequent diagnostic uncertainty. We have effective treatment with glucocorticoids, but with a lot of morbidity related to these drugs. So when I started researching GCA back in 2009, I've taken a multi-pronged approach to this understudied disease. So there was one before we started researching in South Australian GCA, there was one Adelaide paper of 5 cases from the Royal Adelaide, which was published in 1980. And there were some case reports as well. So the approach we've taken is an epidemiologically and data linkage and research, genetic and clinical research, and also addressing the outcome measurements in this disease. So this is the paper I was talking about, 25 patients treated at the Royal Adelaide. And interestingly, 4 out of those 25 patients developed a monocular blindness, and one had the rare complication of gangrene of the tongue, and one had a brainstem stroke. GCA is an interesting disease because there's big differences between populations, and you'll see from these are the incident rates around the world, and it's highest in the Scandinavian countries and in certain parts of the US, which have had large Scandinavian migration, such as Minnesota, but much less common in Asian populations. So we sought to have a look at the incidence rate in Australia, and we did this initially. Our initial analysis was done back in 2013, and we looked at all cases of biopsy positive temporal artery biopsies from SA pathology, which covers most of the biopsies that are done in South Australia, and it's a female predominant disease with a mean age of 78 years. And the incidence in 2013 over that period was 3.3 per 100,000 person years. And we've just updated that analysis. Interestingly, the female-male ratio has altered slightly, and the incidence has also increased. And we think there's elements of ascertainment, so probably the incidence rate is higher than that. And as part of the data linkage, we've also had a look at mortality. So this was a systematic review and meta-analysis that we performed several years ago to look at the mortality with GCA across the globe. Our own data is there and shows no increase in mortality in this disease. Although it's important to realise these patients didn't have an increased mortality compared to the age and sex matched population, but these were in patients who had actually been treated. The hospital cohorts do show an increase in mortality risk, but it's likely these are more severe disease. As expected in this age group and with heavily treated with steroids, the most common causes of death were cardiac and infective. There has been over many years the possibility that this may be a paraneoplastic phenomenon in some patients. So we've also performed a cancer linkage, and we were unable to find a increased risk of cancer in patients with biopsy-proven GCA in South Australia. So the way we've set up the South Australian GCA registry is that all cases of biopsy-proven GCA, which are with temporal artery biopsies performed at SA pathology, we gather, and then patients are contacted through their treating clinician, and then they give consent, and the patients complete questionnaires. There's clinician input, and there's laboratory imaging and DNA collection if the patients are consent. This allows us to give a very comprehensive look at the patients, and this is the first registry in Australia of GCA. So what we found is not unsurprisingly, most patients present with a headache. Visual disturbance is very common. as is jaw claudication, with symptoms of polymyalgia rheumatica less common. Visual outcomes remain poor, with 35% of patients having a monocular blindness in our registry, with 2% having, complete blindness. The mean duration of steroid use is 4.5 years, and most patients will experience some sort of corticosteroid side effect, with 35% reporting 5 or more. So the burden of the glucocorticoids in this group of patients is extremely high. The other area that had interested us was genetic research, and Maureen's group were already doing some genetic research. So together we looked at some SNPs, but also we developed a collaboration with Alex Hewitt and Matthew Brown, Maureen Sue Lester, an international group to do a GWAS in GCA, and we took a different approach than most GWAS do, and that's because patients are so old when they get their disease, it's often hard to collect DNA. So instead of using blood samples, we actually extracted DNA from temporal artery biopsies. This was a massive undertaking, and we ended up with 2,500 DNA samples. There are some issues with extracting DNA, and not all of the samples were usable at the end of the day. Concurrently with this, the Europeans were also performing a GWAS as well, and that was, and our results pleasingly were very similar to theirs, so that the MAP genes, in the HLA-DRB1, HLA-DQA2 all showed increased risk of developing GCA. Our next body of work will be to look to determine whether these HLA associations are also associated with other clinical manifestations and risk of relapse, because 75% of patients with GCA actually relapse, and having good predictors of relapse will be helpful when deciding about the intensity of therapy we require for them. So diagnosis is an issue in GCA. This is the current very old 30-year-old criteria we have for classification of GCA. We don't have any diagnostic criteria, and they're related to age, headache, temporal artery biopsy, ESR and abnormal artery. There's no imaging inclusions, and imaging has been an increasing use in utility in the diagnosis of GCA and large vessel vasculitis. ESR of greater than 50 is in there, but there is no actual data to support this. This was expert driven, and as I mentioned, there's no imaging inclusions, and there's increasing interest in imaging, particularly in ultrasound, PET and MRI. So it is considered the gold standard, the temporal artery biopsy, but it's often not standardised in technique or pathological assessment. So Carly Rudiger, who works with us, has had a look that you need a certain level of certain stretch of temporal artery to get an accurate diagnosis. So we had a look to see whether that was being met in South Australia, and we looked at 825 specimens over the last 6 years. As you can see, only 20% of them were positive, and this is very similar to what's seen both interstate and overseas. The mean biopsy length was 13 millimetres, which was less than the recommended 15 millimetres. So 54% of patients actually had the biopsy was too short, and with no improvement over time. And so if biopsies are longer, there's 25% were positive compared to 17%. And we estimate that we missed up to 19% of cases by having biopsies of inappropriate length. And this hasn't improved over time. So this is a quality opportunity to improve diagnosis. We also wanted to have a look to see whether the ESR of 50, which was whether we could take a data-driven approach to see whether that was actually accurate. And actually we were able to show that when we looked at patients in our cohort. And what we found was the estimated optimal cutoff levels actually came out straight at ESR of 50 and a CRP of 20 with a platelet count of 30. But in data I haven't shown here, actually a combination of a CRP over 20 and platelets over 300 were actually really the best at looking to just about whether the patients did have GCA compared to an ESR. We have a diagnostic study underway with our PH student Gem9 and looking at a comparison of imaging versus biopsy, looking at temporal artery ultrasound, MRI and PET scan. And our other major interest is patient outcome measurement. We initially started this with a qualitative study of patients' perspectives because we were able to measure things related to glucocorticoids, but not some of the patients' perspective. And patients really felt very keenly the problems with glucocorticoids, particularly the mood disturbance, the weight gain, sleep disturbance, as well as the bruising, which many of these are not very well captured in the current ways of measurement. So this has led to an international collaboration with Joe Robson, and we've done qualitative studies in the UK and Australia, and we're in the process of developing a patient-reported outcome measure for GCA, which we hope will be used in clinical trials of GCA. And in alignment with that, we've also done a lot of work related to glucocorticoids. So we've developed as part of the OMA Act outcome measures in rheumatology. We've done a body of work and developed a core domain outcome set for measurement of glucocorticoid impact, and that's will be published this year, and that's been an international collaboration with Sarah Mackey at Leeds University and Susan Goodman at Cornell University in New York. So what are the future directions? Certainly imaging techniques and biomarkers are absolutely required. And we want to look at better predictors of those at risk of relapse and really when and who should be getting biologic agents, and also the role of DMARDs, and we have NHMRC grants in for that. And a PhD student looking at long-term follow-up of patients for large vessel vasculitis complications. So this is our fantastic research group. The PhD students there, particularly Gem9 and Sue Ellen Lyon, who are working in GCA, and Elizabeth Hoon, who's a qualitative researcher from Adelaide Uni, who's been helping us with that part of our work. Thank you.
Thank you very much, Catherine. Think about the vast area of potential collaborations in this cohort of patients, particularly in the area of glucocorticoids toxicity, because I'm sure there are a number of basic scientists and others within our precinct that could actually utilise this very homogeneous group of patients to look into mechanisms. So I will wrap up. I'd like to thank both speakers who really have both led the way in very carefully collated cohort groups of otherwise neglected rheumatic diseases, and have really paved the way for others in Australia to do so. Next Tuesday's presentation is focusing on a special report with Professor Carolyn McMillan, chaired by Professor Steve Westling. So again, thank you for your attendance.